Good afternoon, good evening, everyone. It's day 2 of Dateline Live. We're so happy to have those of you that joined us yesterday back. And if your first time is today with us, welcome. We had a great first day yesterday with some really interesting product information sessions and then a fantastic panel. If you did miss it, those recordings will be up on the HFA website very, very soon. So hopefully you'll be able to join us and be able to see anything that you missed yesterday. So let's jump into our agenda and talk a little bit more about our day. But first of all, I want to say thank you to our sponsors. Without their support, we wouldn't be able to do this very first Dateline Live. So many thanks to CSL Behring, Genentech, Hemobiologics, Sanofi Genzyme, and Spark Therapeutics. We really appreciate your support and your faith in HFA to execute this educational series over the next few days. Also, some helpful hints for Zoom. I know we've all been using it more and more over the last 18 months or so, but it never hurts to remind folks. All attendees will be in listen-only mode for the duration of today's webinar, except when we get to the wrap sessions. So pay attention to your email from this morning. You have a link to a specific wrap session based on what you chose as your diagnosis and registration. And when you click on that, you'll have audio and video for the wrap sessions this evening. If you want to talk to anyone from the HFA staff during the course of today's programming, use that chat function. If you need help with anything, that's where we're looking for that sort of thing. And then to talk to our speakers today, please use the Q&A. That's the spot that our speakers are looking for everything and want to communicate back and forth with you. And just another reminder that everything's being recorded except for the wrap sessions so that we can play it back for folks that were unable to join us live. A little bit about today's schedule. I'm going to move this screen down so I'm not looking weirdly up at you. But we're starting today with a little bit of a game. And if you saw your email this morning, you should have a bingo card. Now would be a great time to press print on that because we're going to play a little bingo with all of these acronyms that come up in our bleeding disorders world. What in the world do they all mean? Then we'll have our product informational sessions from Hemobiologics and Sanofi Genzyme. We'll take a little break, be a great time to, again, check that email for your wrap session link, get a beverage, get a snack, whatever you might need. And then after the break, we'll come back and we have a clinical research manager from the University of Colorado Hemophilia Treatment Center to talk about what it means to participate in a clinical trial. And then, of course, we'll move to our wrap sessions. If you didn't get a wrap session link in your email this morning, just drop us a chat, tell us which one you're looking for, and we'll get that link to you as quickly as we can. So with that, we're going to hop into our bingo game, and I'm going to ask my partner in crime, Miriam Goldstein. Miriam is our HFA's policy director and principal legal counsel to join me in a game of bingo. Miriam, I think you and I might be calling bingo here by ourselves for a few minutes until Dr. Sidonio is able to join us, but we will surely have fun with this. Miriam, any words to say before we hop in?
No, just really happy to be here with you. Thank you all for attending, and Sanja and I are gonna try and make this fun as well as educational.
There you go, there you go. Education through recreation, dating back to my high school recreation days. So go ahead and let me explain some rules. If you do need a bingo card, here is the link that you can print that out, and I'm going to throw that in the chat as well, so you can print out a bingo card. But the way this is going to work, I'm sure you're thinking, Sanja, you're crazy. How are we going to call out bingo if we don't have audio? Well, we're going to use that Q&A box. So if you get bingo, just type bingo in the Q&A box, and we are keeping track, I promise. We're going to just keep playing. we're not going to restart the game each time someone gets bingo. But if you do get bingo, put it in the chat, and then we'll mail you a little special HFA prize in the coming days for winning this game of bingo. So I think that's the main rules. Miriam, am I forgetting anything?
I think
No. All right. Well, I'm going to get my handy little bingo letters here, and let's play. All righty.
So Sandra actually had an official bingo ball cage, and it made just a really bad noise over Zoom. So in the interest of all your eardrums, we're doing it old school.
Yeah, we're going to go to just drawing acronyms out of a much quieter box. So we're going to go that way. All righty. So our first acronym is actually not an acronym. How appropriate. Medicaid. So let me click on that for you, Miriam. There you go. Tell us a little bit more about Medicaid and why it's so important to our bleeding disorders community.
And you know what? Your slides did not.
Oh, they're not showing. Let me
So,
try that. Whoops. Well, if you want to go ahead and start talking about Medicaid, that would be great. Let me work on that while you are talking.
I am happy to do so. So Medicaid is a form of health insurance that is a federal state. It's showing up now, Sanja. It's a federal state partnership. So it provides public health insurance for people with low income. Our slide is actually a little out of date. The slide says it covers 1 in 5 low income Americans. In fact, because of the pandemic, Medicaid is structured to provide, to be countercyclical and to really kick in and help people in times of economic distress or natural disaster, both of which we have right now. So right now, Medicaid is actually covering almost 1 in 4 Americans. So as I said, it was passed in 1965. It originally covered low-income families with young children, but the Affordable Care Act said states could expand their Medicaid programs to cover all low-income adults, regardless whether they're parents, regardless whether they're disabled. And so as of last month, 39 states had adopted Medicaid expansion. It covers, we think, about 30% of people with bleeding disorders. So a really important segment of our community.
Awesome. Thanks so much, Miriam. Let's go back to the bingo board and draw another acronym. Sorry, my hands are super dry. All right, this one's a good one. ABTSA. Miriam, tell us about that one.
The ABTSA is one of 2 federal advisory committees that advise federal agencies on matters pertaining to blood safety. ABTSA advises HHS, the U.S. Department of Health and Human Services. The other federal advisory committee advises FDA. And ABTSA's charter, the 2 have slightly different charters. So ABTSA advises on issues of safety and availability and takes a little more of an economic focus than the other advisory committee, which advises the FDA on matters of safety and product safety.
Awesome, thank you. All right, no bingos yet, but that makes sense, right? We only have two letters gone, so let's draw another one. And our next one is MASAC. This is great because that term was used yesterday as part of our programming, and not everyone might know what that stands for. So Miriam, I'll come back to you.
So MASAC is the Medical and Scientific Advisory Council, which operates under the auspices of NHF. So it gathers together treaters, doctors, nurses, pharmacists to make specific recommendations on treatment, research, and care for people with bleeding disorders.
Awesome, thank you. We hear a lot about MASAC. MASAC provides those recommendations and guidelines, and a lot of folks look for those recommendations, especially when you're making a treatment change, right? So it's very important. All right, we'll go back to our bingo board. And HTC, I bet most everybody knows what that one stands for, but let's see here. I actually can't find it on my board. Give me a second. Here we go. HTC.
So our specialized treatment centers. So I think the federal law dates back to the 1970s, providing funding to establish a network of specialized treatment centers, just recognizing that hemophilia and bleeding disorders require a really specific set of expertise and practitioners. And so courtesy of this federal law that goes back to the 70s, there is some funding to help support these specialized clinics that bring together doctors, nurses, physical therapists, social workers, a whole range of health professionals that can provide comprehensive care, provide care for all aspects of a pretty complex disorder.
Awesome, thank you. We're 140, 150 HTCs across the country, I believe. Does that sound about right to you, Miriam?
That's, yep.
Yeah. So.
And you can find a list of them on the CDC website, which is super helpful if you are traveling and want to know in advance where you might need to go in case of an emergency. And we had a great session yesterday. I'll pitch it because Sandra said the recording will be available, that talked about it brought together providers and patients and caregivers. And in the course of that conversation, we got to talk about some of the resources we have for having a successful clinic visit and negotiating those aspects of your care.
Absolutely, thank you. All right, well, let's move on to our next one, and it is OOP. So let's click on that one and see what that one's all about.
So OOP, I don't know if it's a formal acronym or not, but it sure beats saying out-of-pocket expenses. So out-of-pocket expenses, we all know that negotiating insurance is really hard and there are lots of costs. Out-of-pocket expenses refers to the portion of costs that you pay after you've paid your premium. This is the part that you have to pay to use your health insurance and to get your care. So it's deductibles, it's co-pays, it's co-insurance, it's all the amounts of money that you have to pay in addition to what your health plan is paying for your care.
Awesome. Thank you so much, Miriam. Miriam is a wealth of knowledge. If this is your first time hearing Miriam speak, you will learn something today. So, all right, our next one, it's kind of a combination, is the Roman numerals FVIII or F8. What does that stand for?
So factor 8. So also the protein that people with hemophilia A are missing or not producing in sufficient amount.
Yeah, I think some of these are pretty familiar, some of them aren't, but they can be used interchangeably. So I think it's important to, as a patient, to know if you see either one of these, that it really does mean the same thing. All right, let's hop back to our board. Still don't see any bingos yet, so that's good. And I've got FDA, and that is over here under some of our federal agencies. Tell us about FDA.
So the FDA administers the Food, Drug, and Cosmetics Act of the 1930s. There have been a lot of laws passed since then. It ensures that food and cosmetics are safe and pure and wholesome, but it also ensures that drugs and medications and medical devices for both humans and animals are safe and effective. It turns out that about 1 out of every 4 consumer dollars is spent on an FDA approved or FDA regulated item, whether it's food, cosmetics, or drugs. So you can see that the reach of the agency is really broad.
Thanks so much, Miriam. Go back. I saw a Q&A. Somebody doesn't like their bingo card so far. It's totally the luck of the draw. I promise all of the acronyms really are on each of the bingo cards. So luck of the draw. I think there's 50 some acronyms here and 25 letters and acronyms on your card. So yeah, it's gonna be a tough one. But all right. COT, you have a history with COT, Miriam. Do you want to tell us a little bit about COT?
I do. Back when I was kind of a old intern for COT, I did some volunteer work for them back in the day, but COT was founded in 1989. It's a grassroots, peer-led advocacy and support organization, largely for people with bleeding disorders who are also affected by HIV and/or hepatitis C, coming out of the 80s and early 90s when our products transmitted infections to the community. So COT is, it's very near and dear to COT's heart to advocate for a safe and available blood supply and to empower and advocate for people affected by or living with bleeding disorders and HIV or hepatitis C. Thank
you. Over the years, I can say I've learned a ton from COT members and really value so much of the work that COT has done over the years. So thank you very much. I bet there's a couple of COT board members on this call today, so we very much appreciate. EHB, another insurance term.
So EHB is essential health benefits. This is one of the concepts that was put into law by the Affordable Care Act. So under the Affordable Care Act, ACA health plans have to cover a set of 10 categories, broadly defined categories of health benefits. So this includes hospital care, it includes emergency care, it includes maternity benefits, and crucially, it includes prescription drugs. It was really a key innovation of the Affordable Care Act to say health plans, you have to cover people regardless of their pre-existing conditions. And you know what? Your health coverage also has to meet their needs. Important to know that the essential health benefits provisions of the Affordable Care Act don't apply to everyone. So if you get your health coverage from an employer in something called a self-funded large group plan, essential health benefits don't apply. The thinking kind of was those large group plans already have a pretty generous range of benefits. And so where we need to focus these requirements is in the individual market. But it was really a key advance and one of the really core protections of the Affordable Care Act.
Absolutely. I remember lots of advocacy work back in the 2009, eight, nine time frame of working on making sure that those essential health benefits were part of the Affordable Care Act. So let's go back to our board. And Gina, oops, I knew I would do that at some point. Gina is not just a cool girl's name, it is also a law. Tell us more, Miriam.
So GINA is the Genetic Information Non-Discrimination Act. It was passed really just before the Affordable Care Act. And so it prohibits, protects against certain kinds of discrimination based on certain kinds of your genetic background, your genetic information. So it protects against discrimination in health insurance and in employment. Now, the GINA's protections against discrimination in health insurance kind of have been replaced by the Affordable Care Act. Under the ACA, no health plans can discriminate against you because you have a genetic condition. But the protections against discrimination in employment continue to be an important part of GINA.
Thank you. All right, we're going to go on back. I do see that chat in the chat box. If someone from the HFA staff could take care of that for me, I'm just going to throw that out there. That would be great. Thank you, guys. And we're going to go back to our federal agencies and NIH.
So National Institutes of Health, very much in the news right now, under the very long-term guidance of Dr. Francis Collins. They played a key role in research into how do we get out of COVID. But before that, they just have played a really key role in biomedical and behavioral research within the US and abroad. It has several institutes under NIH, including NHLBI, which is where research into blood disorders lives.
Beautiful campus in Bethesda, Maryland. Really, really beautiful campus. Hope to get back there someday just to walk around. So it's beautiful. One of these days we'll all get to travel again, right?
And the cicadas are now gone.
Oh, good. That's even better.
They would have been making a din on the NIH campus.
Even better, even better. Yes. So, all righty, we have another kind of federal project here, Miriam, and that's UDC.
Universal data collection. So I remember signing my sons up for this when they were young. So it was a research project under the auspices of the CDC to compile really useful data about health outcomes and experiences for people with bleeding disorders. So you can see it ran for over a dozen years. 27,000 people with bleeding disorders contributed their data. There were blood samples that were banked during that time. There were joint range of motion studies and examinations that were conducted and the information compiled. And it just provided a wealth of data. UDC has ended, but that work continues now via the Community Counts program, which is housed in Athen, which may be one of our other acronyms that will come up, and still funded by the CDC.
And we're going to hear more tomorrow about community counts in our Get Counted registries session tomorrow. I think it's it's our first session tomorrow. So if you're interested in learning more about that, please join us again tomorrow, and we'll talk more about that. All right. So next up, I have HIPAA, which I love that I keep messing that up. So I knew I would. It's very, very sensitive. Let's go HIPAA. All right, there we go.
So HIPAA is it's an acronym that everyone always gets wrong because it sounds like it's got two P's and one A, and it's the opposite. It was a law. This is another law that some of its function has been eclipsed by the Affordable Care Act. So when HIPAA was passed in 1996, one of the important things it did was it said if you were continually insured, but you were moving from one plan to another or one job to another, your new health insurance plan couldn't apply a waiting period to cover your pre-existing condition. As long as you were continually insured, that coverage had to kick in right away. That is not so important anymore under the Affordable Care Act because there can't be waiting periods for coverage of your condition. Your pre-existing condition is covered from the get-go. But the privacy portions of HIPAA continue to be very much in effect and honestly very much misunderstood. So HIPAA creates confidentiality obligations on the part of healthcare providers, insurers, and employers to keep your private health information private. They can't disclose it without your consent. But it doesn't limit, you having a conversation with a friend, or there's been a lot of, I would say, inaccurate discussion of HIPAA, especially in the COVID context and around vaccination and some issues like that. It does provide really important protections for the confidentiality of your information on the part of people who have that information because they're caring for you or they're insuring you or they employ you, but it doesn't apply in your social interactions.
Awesome. Thank you. It's probably one of the first forms that you sign at any medical appointment. You're there, and no matter if you've signed it once before, you're going to sign it again, my friends. So it HIPAA is very important in our medical friends world. All right, you good, Miriam? Ready to keep going? Still no bingos, so we're gonna just keep plowing through here. All right, the next one is access. Since I keep wanting to click over that anyway, good. Finally, I drew it. There you go.
So access is a free legal aid, advice, and assistance program that is operated under the auspices of PSI, Patient Services Incorporated. It provides free legal help to families facing chronic medical conditions, including bleeding disorders, especially with matters like disqualifying for Social Security disability, for pursuing SSI claims, and so on. You can find a link if services of this sort are something that you're interested in. You can find the link on the HFA website under our patient assistance portal.
Absolutely. Absolutely. Thank you, Miriam. We'll hop back over to our bingo board. Still no bingos. So we'll see. I think there's some of our HFA staff playing along. So if you guys get bingo, you can scream it out in the Q&A too. We'd love to see it. You just won't get the prize. So all right. One of your favorite things to talk about here is ERISA. So let's hear more about
that. Sorry. ERISA is a sprawling piece of federal legislation that deals with pensions and all aspects of retirement. But among other things, it regulates those self-funded employer-sponsored group health insurance plans that we mentioned earlier. And if your plan falls under ERISA, that means that state laws generally don't apply. So when we are in your state, working with your state member org to advocate for protections against step therapy, or guardrails on step therapy, or protections against accumulator adjusters, those are really important efforts. We hope you will add your voice to them, but understand that some of those state laws that we're advocating for do not protect you if you are in a plan that is regulated under ERISA. to affect those plans, we have to advocate at the federal level, and we do.
Yeah, lots of work this year, in particular in the states. I'm going to veer us off course just for a minute, Miriam, but you want to talk a minute about some of that work in the states with accumulator adjusters? I know I'm getting ahead of one of our acronyms, but maybe you can take a minute to talk about some of that work in the states this year.
Sure. Well, accumulator adjusters, you've all probably heard about now, and it is actually one of our acronyms, but this is an insurance company tactic that basically limits the ability of patients to benefit from manufacturer copay assistance programs. The idea on the part of the insurance plan is we want to incentivize patients to use cost-effective generic medications. And so we are not going to count manufacturer-provided copay assistance toward a patient's deductibles and out-of-pocket expenses. We're going to keep drawing down those funds. So your first or your second prescription, you're going to say, oh, my copay is covered by this program. And you're right, won't pay your copay. But eventually the copay assistance dollars are depleted and you go to get your refill and all of a sudden you owe your full deductible and potentially up to your full out-of-pocket maximum, which can be thousands and thousands of dollars. That's a big problem for patients because most of us can't afford that. And people who live with a chronic condition and use a medication for maintenance purposes for life, we're facing those expenses year in, year out, and it's just a really significant financial burden. And when that deductible hits all at once, and often as a surprise, people can't pay that, and then they can't pick up their prescription, and then they have breakthrough bleeding, or they have to end up in an emergency room. So it's a big problem for patient access and for patient health. We are trying to address accumulator adjusters at the federal level, but we had hit a couple of dead ends in 2020 at the federal level, and through a coalition working on these problems, decided let's focus on the states and kind of regroup and figure out a new approach at the federal level. So as of now, I think there are, it's either 10 or 11. I think
it's 11 as of this week. As
of this week, states have passed protections against accumulator adjusters, which is fantastic news for people in ACA marketplace plans in those states. Any copay amounts paid towards their copays count towards their deductible. So those manufacturer copay assistance dollars, they count. They count, and your deductible is satisfied with those dollars, and you don't have to fear that sudden, when you go to get your refills, suddenly facing a massive out-of-pocket expense. Efforts are continuing in about half a dozen states where the legislature is still meeting. And as I said, we are also working at the federal level to try and get a solution that works for everyone, including people in those ERISA plans that can't be affected by state law.
Yeah, and I did veer us off course, but I did it on purpose and I haven't clicked on it yet, but I want to share that the acronym that most everyone knows about accumulator adjusters has been AAP, but it really is kind of gaining traction, copay accumulator. So everything Miriam just said is on this slide, but just in case you start seeing CAAP and like, that's a new one to me. It's not. There's just been an added letter to the first part of that acronym. All right. And again, many congratulations to several of our member orgs. It's been an amazingly successful state legislative season in 2021. It's been really exciting to get so many wins for our community. Okay, next up is WHF. So let's learn about WHF, Miriam.
And your cursor went the wrong way.
I went the wrong way. Let me do this again. Whoops. There we go.
So World Federation of Hemophilia is the global counterpart to organizations like HIPAA. So it is really working globally to achieve treatment for all people with bleeding disorders around the world. And obviously, there are challenges at the US level. There are a lot more challenges in some of the developing countries. And so WFH runs humanitarian aid programs. They run programs where they try to partner national organizations from more under-resourced countries with national organizations in places like the US or Western Europe that can provide development help and, advice in how to get your advocacy activities and, effective patient assistance programs up and running. WFH has also come out with some treatment guidelines, and they have launched a global bleeding disorders registry. And we're going to talk more about registries tomorrow, right? In one of the sessions of Dateline Live.
We are, yeah, absolutely. World Federation does some amazing work, and we're happy to partner with them from time to time. We did have a chat question. I just want to address it for the whole audience. If AAP still appears on your bingo cards, you can count that for CAAP. So it literally is breaking news that it's a new term. So might not have made it on the prints. So, okay, let's go back to insurance terms, and we'll do PBM. Also, major kudos, how do you say it, to Miriam, because she has no idea which one I'm going to pull and call. So this is, not that she doesn't know this information like the back of her hand, but it is entertaining watching the brain switch very quickly. So PBM.
So PBMs are kind of an entity. They're a third-party entity that stands sort of between the health insurance plan and you. They are develop formularies for health insurance plans, and they manage the pharmacy, the prescription drug benefit for health insurance plans and for public programs like for Medicare, for Medicaid, and other state government employee plans, other public insurance. PBMs, their role is somewhat controversial. I think the PBM industry would say, look, we help limit costs. We negotiate really good deals for the payer by negotiating rebates on prescription drugs. The pushback to that argument is, yeah, you're not really operating in a very transparent manner. And so who is getting the benefit, the savings from those negotiated price concessions? Are those savings really making their way to patients out of pocket? Or are those savings really making their way to the payer in a way that keeps premiums down? And there's a fair amount of controversy over that. So expect to see a lot more talk about PBMs. There's been a lot of talk about them for many years, and it will continue.
Absolutely. Okay, we'll go back to our board. And we've got PCP. That one got used yesterday. You want to talk a little bit about that?
So that's a primary care physician, so also called an internist or a general practitioner. And they're supposed to provide your everyday care, not necessarily your bleeding disorders care. And there's been some talk of, HTC professionals who say, our patients are kind of looking to us for too much of their primary care, or there are other people in our community who look to their primary care physician for their bleeding disorders care. But this is really routine care for kids. It's the pediatrician, and so it's all of those pediatric vaccinations. It's when you have strep on the weekend. It's when you cut your knee and need a stitch, as opposed to a bleeding disorder complication.
Absolutely. Thanks, Miriam. I can't believe we're 40 minutes into this and no one's cried bingo yet. Incredible. So holler if how many do you have, guys? Do you have 3, 4? Are you getting close? Hopefully you are. I really do promise they're on there. They the acronyms certainly are on there. So we got 2. Okay. So yeah, it's a lot of acronyms. And if we don't get through all of these today, we will be providing in your post-event mailing. So a little Dateline live gift in a few weeks to arrive in your mailbox, a glossary of all of these terms, just in case we don't get through all of them today. So I see somebody says they need 2 more. We're getting there. We're getting there. So, all right. The next one I pulled is ADA. Again, I bet that one is something that is familiar to most folks.
So the Americans with Disabilities Act is a civil rights law, prohibits discrimination based on disability in a number of contexts. So in the workplace, it protects against discrimination on the basis of disability or perceived disability. There have been cases that have actually influenced the development of ADA law involving bleeding disorders, where people were assumed to be incapable to do a certain job because of their bleeding disorder. And the courts and subsequently the federal agencies said, you can't make that assumption. There are you can have certain objective tests about, can you lift 50 pounds if it's, if that would be essential to your job, but you can't assume. And so the protections apply in the hiring context, not making those assumptions, and then in the workplace context. So if you have a job and maybe you're experiencing a bleed or a health issue and you need a reasonable accommodation. If that accommodation is reasonable, your employer can reasonably make it. Maybe they can give you a stool to sit on instead of you standing for part of your shift. Then the employer is required to make that reasonable accommodation. The ADA also provides protection in a bunch of other contexts, including education, transportation, housing, and a number of other contexts.
Absolutely. Thank you. One of my college classes sent us out measuring ramps and stairs and measuring our local arena to see just how ADA friendly it was. So that was an interesting time. So, all right, I've got another very timely one and interesting insurance term here for you, Miriam, and that's COBRA. Whoops, let's not do that one. There we go, sorry. Talk about, geez Louise, sensitive. There we go, COBRA.
So COBRA is super timely. Thank you, Sandra. First of all, it's got a ridiculous name. So it's got an acronym that sounds like a snake. It's got a name that doesn't actually tell you anything because it was part of this, an omnibus bill is a giant bill that covers a whole bunch of things. And so it dates back, I think, to the 90s. And what it does is it gives workers and their families who have insurance, health insurance through a job, the right to continue their group health insurance after losing their job in certain circumstances. So you can't lose it for gross misconduct, but if you experienced a layoff, or if you had your insurance through a spouse and there was a divorce or a death in the family, if your child aged out of coverage, there are certain circumstances in which you can continue your health plan coverage under COBRA. It is for limited periods of time, and it is very expensive. So most people who get health insurance through work, your employer is paying a pretty healthy chunk of your premiums. You may be paying part of it, but your employer is paying part. If you exercise your COBRA rights, you have to pay the full premium, the employer share and your share, plus 2% to cover administrative costs. So it can be a very pricey option. The reason it's so timely, as Sanja said, to talk about COBRA is that in March, Congress passed and the president signed a big COVID relief package. And, Congress and the president realized that a lot of people have lost their jobs during COVID. And so part of this COVID relief package tried to make health insurance more affordable for people. And one of the things it did was it said for a very limited time, from April to September 30th of this year, if you lost your job involuntarily, or you had your hours involuntarily reduced, and you want to continue your health plan coverage under COBRA, the government will pick up, will 100% subsidize those very expensive premiums for you. So it's time limited. It's only for a small category of COBRA eligible people, only those who involuntarily lost coverage. And it's only until September 30th, but it could be really important to someone with a bleeding disorder who falls into that category, because you've likely met your deductible by this time of the year. So maybe it makes more sense to extend your coverage under COBRA rather than starting over with a new plan. Again, the subsidy only lasts through the end of September, but at that point, if you haven't found a new job, found new coverage through a new job, you can then go into the marketplace and get subsidized a new plan that is subsidized. This stuff is really convoluted. I cannot believe that anyone would absorb and remember this material from hearing me talk about it in the middle of bingo game. So you should know that we have resources on the website that can walk you through your insurance options if you have lost coverage because of COVID, and all the new opportunities that are available by virtue of the American Rescue Plan, which is the law that was passed and signed into law in March.
Thank you, Miriam. Always, always, always a depth of knowledge. And you've mentioned a couple of resources, and during our break today, I'll put those in the chat for everyone to see. But more importantly, we have a bingo. Susan has COBRA, Access, WHF, HIPAA, and HTC. So congratulations, Susan. We'll get you, make sure you get your prize. So glad someone got it. I was getting worried. So, all right, our next acronym here is HHS. Where is HHS? There we are.
All right.
HHS.
So HHS is a federal agency. It is the U.S. Department of Health and Human Services. Its mission is to enhance and protect the health and well-being of all Americans. And it is huge because HHS is the parent agency over FDA, which is already huge in and of its own right, over NIH, over the CDC, over CMS, which is one of the ones you haven't pulled yet, Sanja, but so really big federal agency here in Washington charged with overseeing health and human services.
Thank you. I promise I'm not pulling which ones I want to. I'm just trying to get a few lined up here so that we've got them ready to go. So let's go back to insurance, because that's the world we know. And HDHP.
So HDHP are high deductible health plans. The world has kind of caught up to HDHP in that almost all health plans now are high deductible. Unfortunately, that's been a real shift in insurance plan design. But high deductible health plans have a special feature, which is that they, under federal law, they can be coupled with a tax privileged health savings account. So that health savings account allows you to save money. It could be money you put in, or sometimes your employer may put in, and it accumulates tax-free. And you can use that to pay some of the deductibles, those high deductibles that have to be satisfied before the plan itself starts paying towards your care.
Thank you. Okay, let's go with our next one. And we're back to this one really, and on my chart here should have maybe fallen under law and regulatory, but it also comes up in insurance, and that's FMLA.
So the Family and Medical Leave Act requires employers of 50 or more employees. So it's, you know, they kind of recognize maybe for mom and pop shops, this would be a hard benefit to mandate, but to give up to 12 weeks of unpaid job protective leave. So that means when you come back after taking this unpaid leave, you have to come back to your same job and your same pay level for caregiving activities associated with different health or adoption life events. So it became, you know, really important during COVID, especially with the idea of quarantining or self-isolating if you or a family member had been exposed. So even if you weren't necessarily sick, could you take leave to try and contain the spread of COVID? And FMLA was really critical to that.
Thank you.
It can be hard to use because it is unpaid leave. So, but at least it says your job will be there for you if you can afford to ride that period out.
Absolutely. So important for those that maybe need to take time off due to a bleeding situation or any other health concerns.
A clinic visit, you know, anything like that.
Yeah, yeah. All right, this is one that you mentioned earlier, and we'll learn more about tomorrow too, but let's talk about Athen a little bit.
So Athen is a nonprofit organization that now conducts the community count survey. It partners with hemophilia treatment centers around the country to collect and manage data from those surveillance projects. And Athen, in collaboration with the CDC, houses that data, conducts research, publishes research, all with the goal of improving care for and lives of people living with bleeding disorders.
Thank you. We are doing well. We've got about 6 minutes left, Miriam, and we've gone through a good number of these. Next up is CMS. You also referenced that one a little bit ago.
Yeah. So CMS is one of those agencies under HHS. It's actually huge. I looked it up. It's 6,000 employees. It administers Medicare. It administers the federal portion of Medicaid, because Medicaid is a joint federal state program. It administers the children's, again, the federal portion of the Children's Health Insurance Program, but also the rules for the ACA marketplaces. And an office of CMS makes rules for health insurance offered through the marketplaces. It turns out that almost half of Americans coverage falls within the purview of CMS, 149 million Americans.
Thank you, Miriam. Gonna get back to that bingo board. Okay, so I'm gonna make sure I spell this one out because it's very close to another one, and it's C-B-E-R, CBER. Kind of a wonky one, but important nonetheless.
So CBER is a division of the FDA. And so CBER stands for Center for Biologics Evaluation and Research. And they overlap with the one that Sanja said sounded alike, CDER, which is drugs. CBER is biologics. So biologics are products like clotting factor. They're products derived from living cells. So CBER regulates those biologics, but also blood, so blood donations and blood-derived products, and vaccines, as well as tissue implantation or transplant, and cell and gene therapies. So a lot of our products are regulated through CBER. CBER has been very much in the news with the development of COVID vaccines, and they've been working really, really hard for the past 18 months.
Thank you. All right. Next up is Medicare, which I'm glad we got that one drawn, because even though it's not an acronym, it really is easy, to get Medicare and Medicaid mixed up. So Miriam, if you don't mind explaining the difference.
So Medicare is generally, not exclusively, but generally the health program for people age 65 and over, with that age of eligibility rising in the next couple of years. It provides public health insurance for people who are eligible, regardless of income or medical history or health status. So this is where money is taken out of your paycheck for as long as you work to go towards your Medicare after you retire. The program was expanded in the 70s to cover people even under that age who have a disability. And then in the early 2000s, it was expanded to include a drug benefit. Medicare hadn't covered prescription drugs until the early 2000s. Clotting factor actually is covered in a different part. So clotting factor was covered, but the other drugs that people tend to need as they age were not covered until 2000. Today, people have the choice of getting Medicare either through traditional Medicare, Part A and Part B from the government. With bleeding disorders, you need to get a supplement to cover the cost sharing that comes with Part B. Or people can get Medicare Advantage, where their Medicare benefit comes from a private company and it's run kind of like an HMO. There are lots and lots of choices to make as you approach Medicare eligibility. And it's really important to do your research. Again, we have some resources on the HFA website. An HTC social worker would also be a good resource. And every state maintains what are called SHIP programs, which is Senior Health Insurance Program. They are free. They are non-biased. They don't get commissions or anything, and they can be a source of information for people as they start to approach that Medicare eligibility age.
And exciting that so many in our community are starting to age into Medicare. It's kind of a new territory for us. We have 1 minute, probably less than a minute remaining, but I did pull this one, and I think it's important that we do it because there was a big victory, big news last week about this one, and it has been very important to our community for a long time, and that's the ACA.
the ACA, also known as the Affordable Care Act, sometimes called Obamacare. So it was enacted in March 2010. The last in-person event I went to in Washington was a 10th birthday party for the Affordable Care Act. It really affects everyone in the US in their healthcare, whether you get your insurance from the marketplaces or from an employer, whether you're covered by Medicaid or from Medicare. And in the 11 years since its enactment, it has really changed people's baseline expectations of what health insurance does. We now take it for granted that health insurance can't discriminate against us because of a bleeding disorder or other pre-existing condition, but that wasn't always the case. We now take it for granted that there are not lifetime or annual caps on our benefits. That was not always the case. We take it for granted that we can keep kids on our health plans as parents till age 26. That was not always the case. So all of those come from the Affordable Care Act. The Affordable Care Act has been challenged in court numerous times, and last week survived its third challenge in the Supreme Court, a case where some attorneys general from some states sought to overturn the Affordable Care Act as unconstitutional. And the Supreme Court disagreed, said that there was no standing to bring that challenge. And it appears that hopefully those existential challenges to the Affordable Care Act are now over.
Thank you, Miriam. And again, I just want to say many props to you for taking up the challenge today of answering acronyms on the fly. It is always a fun game to figure out those acronyms. But thank you so much, Miriam. You are a blessing for our community, and we're very lucky to have you be able to teach us all about all these great acronyms. Just as we start to move into our next portion of our programming, I just want to say again, thank you to everyone. If we didn't get through all of those acronyms, that you missed some on your board, we're going to put together a little resource, and in your event mailing that comes in a few weeks, you'll have a list of all of the acronyms and what they mean. And I did take a quick peek as we were playing bingo, and for those of you that were with us the whole time, we're gonna make sure you get a prize, whether or not you got bingo or not. You stuck with us for the hour, so we're gonna make sure that you get your prize, because that's only fair, right? That's only fair. Welcome back, everyone. Hopefully you had a nice break. We're able to grab a beverage or whatever else you needed to keep you going here, but we're pleased to have you back. If you're just joining, my name is Sandra Wilkes. I'm the VP of Policy and Advocacy for the Hemophilia Federation of America, and it's really an honor to have you here today. We're so grateful that you took the time to learn a little bit. Hopefully, if you were with us earlier, you enjoyed bingo and learned a few acronyms that maybe you'd heard before but weren't quite familiar with. Before I introduce our next speaker, just want to go over some quick Zoom etiquette reminders once again. The audience will be in listen-only mode throughout the rest of the presentation today. And when we go into our wrap sessions, you will be able to use your audio and your video. Those are different links, so you should have gotten that in an email earlier today. But if you didn't, just drop a note in the chat and we will make sure you get the right link. About the chat, use the chat to be in touch with the HFA staff. We're here to help you and try answer any questions that you might have. We'll also try to provide some resources in the chat as our next presenter is talking. If you have questions for our presenter, for our speakers, use the Q&A. That's the spot that speakers know to look, and we'll be looking for your questions there. So that's the rules of the road for Zooming. You know, I think most of us know it by now, but just never hurts to remind everyone. So our next speaker is here today to talk a little bit about clinical trials. And I think it's an interesting topic for us in the bleeding disorders community, because every one of our bleeding disorders is considered rare, which means that there's under 200,000 people in the United States with that particular disorder. So that means that researchers are definitely interested in us as a patient population and in medical advancement for that particular disorder. So Julie Smith is a clinical research manager at the University of Colorado Hemophilia and Thrombosis Center. She is one of the most caring, kind persons you'll ever meet. And it's my honor and thrill to introduce you today to Julie, who's going to tell us more about what it's like to participate in a clinical trial. Julie, the floor is yours.
Sanja, thank you so much. I am so excited to be here and speak with all of you today. I am just going to pull up my presentation here. All right. Hopefully everyone can see my presentation, the PowerPoint. So like Sanja said, my name is Julie Smith, and I am one of the clinical research managers at the Hemophilia and Thrombosis Center in Denver. And I was honored, and it's my privilege to meet with you guys. When she asked me to speak, I was thrilled. And then when she said, talk about clinical trials, I was even more thrilled, because that is my strong suit. So before we dive in, I wanted to tell you a little bit about me and about our HTC and the team that we work with. And before you look at this and think, oh my gosh, we're scraping the bottom of the barrel here with Julie talking today. So back in 1994, the classic all-time favorite movie, Dumb and Dumber, went to the theaters, and I loved it. I was in the 5th grade, and I thought it was hysterical and hilarious. And I am originally from Alabama. I'm actually in Alabama on vacation visiting my family. And these little water droplets on my screen, that is the humidity of Alabama. I wanted you guys to feel like you were here with me. So you'll see these little water droplets, and that's the humidity of Alabama right now. So fast forward, let's see, for those of you who don't know Dumb and Dumber, haven't seen the movie, let me just give you a little brief synopsis. This lady left her briefcase of money in an airport, and a dumb limo driver named Lloyd and his best friend Harry decided to go on a cross-country road trip adventure to Aspen to return this briefcase of money. And fast forward about 12 years, I received my degree in biology from the University of Alabama, Roll Tide. I was a student there before we won national championships, so I'm a true fan, not just a bandwagon fan. But so after I graduated, I remembered how much I adored the Dumb and Dumber movie and Aspen. And when you're not from Colorado, you think all of Colorado looks like Aspen. And I wanted to live in a snow globe. And so I asked my best friend if she would be willing to be like Lloyd and Harry and make a cross-trip country to Colorado to move and see what life was like, and see how wonderful it was, and see if it really was idyllic like the Dumb and Dumber scenes. So sure enough, we get to Colorado, and we realized that Colorado isn't all like Aspen. It's not resort town living. The money is not endless. And like Lloyd and Harry, the pot of money was leaving quickly, and we needed to get jobs. And so I started applying for work so that I could pay bills and see if life would work in Colorado for me. And I landed a job at the university doing type 1 diabetes research. And it's funny because in that interview with the Barbara Davis Center for Diabetes, the last question that I think sealed the deal. It was a panel of interviewers. And the last question, I guess, to see if I fit in with their group was, what's your favorite movie? And here comes Dumb and Dumber. I tell them about that. I tell them the story. They hear my thick accent because I had just moved. And as soon as I answered their question, after they finished laughing, they offered me the position. So I am convinced that my love of Dumb and Dumber and moving across the country in pursuit of the Rocky Mountains is what got my shoe in the door. And so at the Barbara Davis Center, I was taught the foundations of research. A lot of the work that I did there was in device research. So we did a lot of work with the Dexcom continuous glucose monitor. And the coordinators really took me under their wing and taught me the foundations and the fundamentals of research. And a few years later, a research opportunity opened up at the Hemophilia and Thrombosis Center. And this is our building. It's lovely. We are growing. We occupy the first and almost all of the second floor now. And the directors of our center are Dr. Marilyn Manko-Johnson and Dr. Mike Wong. We have amazing, brilliant hematologists that we work with. They lead us well. We have a clinical team, which is comprised of nurses, physical therapists, nurse practitioners, physician's assistants. We have anti-coag pharmacists. We have a licensed and accredited 340B pharmacy. We've got a whole pharmacy team. We have our finance team, our psychosocial team, our wonderful IT and admin that keep us running. We also have wet lab translational research facilities where a lot of work is done. And the group that I'm a part of is the clinical research department, and that is the human subjects research projects. And so that is where we're gonna spend most of the time today talking about human subjects and clinical trials. You might ask, why did I pursue a career in research? I have loved science. I love being creative. I love to think outside the box. I love progress, and I like the idea that what I do is contributing to moving things along. I also really thrive in a team environment. And like I just mentioned, our whole HTC team, we're one big family, and all of us are, our goal is to serve our patients well and give them great care, great service. And it takes a lot of teamwork. I also like working with patients. That is the driving force behind all that we do is our patients. And then specifically, why did I move from the Barbara Davis Center in diabetes to bleeding disorders? I have thoroughly enjoyed the relationships that I have made with my study patients. As you all know, the bleeding disorders that we focus on, they're chronic conditions. Most of the time, patients struggle with their bleeding disorder for their whole life. And so we're really able to develop rapport and good relationships and kind of grow old together. Let's see. So I feel like the past decade, so I started at the HTC in 2011, and since 2011, there has been so much movement and progress and improvements in the novel therapies that have hit the market. And some of those, when I first started, were just the standard half-life products. Everyone was pretty much on those. Then we started doing clinical trials on the extended half-life products. So we wanted patients to not have to infuse as often. Anything we can do to, try and lengthen the time between infusions was a goal. And then that wasn't enough. And so we started trying to, determine how we can make even longer acting products and how can we make the infusions a little bit easier. And so the subcutaneous injections have come out, and there are more things that we are still exploring. So the projects that we have in the pipeline and what we're working on at our center with industry sponsors now more extended half-life products, so longer acting factor VIIIs, different options for subcutaneous injections, whether it's, you know, a recombinant factor VIIa, or whether the fitusirands and all of the sub-Qs that we, everybody knows and is excited about Hemophilia. There are lots of novel therapies that are still we're trying to learn more about, because they are new and we need data. Everybody's excited about gene therapy. There are lots of different opportunities for patients to participate in those types of trials. We've got, for the von Willebrand disease population, we are looking at some recombinant von Willebrand factor studies. We're looking at pregnant women and how we can treat them best through labor and delivery and postpartum bleeding. And then another kind of facet that we are starting to explore is, you know, better ways of pain management. Hemophilia patients struggle with arthropathy from all of their joint bleeds over the years. And, you know, trying to figure out how to manage that pain from those bleeds and is another interest. And so we've come a long way, but we still have so much more to go. And this is the driving force that, you know, keeps industry moving and keeps us at the HTC and, you know, everyone involved. We are trying to learn how to improve outcomes and quality of life for patients. So that is our goal. And this is my team here. So you see me over on the left, and then my co-manager, Christy, is over on the right with the silly face and the gloved hands. And then the picture in the middle is our dream team. They are phenomenal. And this is our clinical research department, who we basically have 8 to 10 projects each that we manage at any given time. So we have a large, robust research program, and you know, the volume of our projects kind of ebb and flow. Some projects may end and others may start, and so we're very busy, but we wake up to work hard for our patients, and yes, we have fun. We take our jobs very seriously, but we don't take ourselves very seriously. So let's see. So what I want to talk to you about today are just the phases of clinical trials, so that you have a better understanding as patients who are presented with these research opportunities. When you hear that it's a phase 1 or phase 2 or phase 4, you know what that means. You know how new it is, how much might be unknown. And we'll talk about that. Then I want to talk about how the clinical trial process works. Who are the different team players and what are their roles? As patients, it's probably difficult to see or understand what happens behind the scenes. You know, oftentimes the patients are involved in the study visits, but they might not really understand what's happening, who's really, you know, paying attention, and who's, you know, making sure things are safe, and who, you know, who's taking care of all the, you know, paperwork and the regulatory piece of clinical trials. And so we'll talk about how the clinical trial process works in the background, just so that patients have a better understanding of what's going on. And then we want to talk about what you need to consider as you decide whether you want to do a clinical trial or not. What are the good things about participating? What are the bad things about participating as you weigh your decision? So let's dive in. All right, so this is just a diagram that shows all of the different phases of trials, and we'll go through each of them in a little bit more detail. So preclinical, obviously the clinical piece is what involves humans. So if it's preclinical, this means these projects are done in a laboratory setting with animals, most likely. There could be, you know, in vitro studies or animal studies. And the goal of the preclinical studies is to see if it's safe to give to humans. You know, like, does the animal tolerate it well? What's the mechanism of action of the study medication? Does it work against a certain disease? What are the risks, or what are the side effects that you observe in this animal? And after enough preclinical data that says, you know, this could be safe in human use at this point, the sponsor of the study is going to submit what's called an investigational new drug application to the FDA. So for short, IND, and the FDA, the Food and Drug Administration. And this application is just going to describe the sponsor's plans to test the study medication in humans. So that's the first step before it reaches humans. For phase 1 trials, this is the first testing in humans. This is typically a small population. Sometimes it's a population of healthy controls, so they might not even have the targeted disease under study. We are looking at safety. We're looking at dose tolerability. And we're looking at things like how is the drug handled in the body? How is it absorbed? How is it metabolized? How is it excreted? Things like that. But safety is the biggest component of phase 1 trials. Then we're going to move along to phase 2. In phase 2 trials, those it's a little bit larger study size, and we are targeting patients with the condition being studied. So in this case, bleeding disorders, whatever the targeted diagnosis is, we want those patients to participate, and we want to look at efficacy and safety. All along these trials, safety and efficacy are the big things that we always look for in all of the different types of trials. In phase 3 trials, these are our larger studies. We are looking at efficacy still. We're looking at risk and benefit ratio. So is there more benefit than risk, or reasonable risk with some patient benefit? These are your randomized controlled trials. So you may have different cohorts. You may be randomized to receive a certain dose of a medication. Another group may be randomized to a different dose, or they might be randomized to a standard therapy. And so these are our big trials that typically happen right before submission to the FDA for marketing and approval. And this application is called a new drug application, and it's basically an application that gives all of the information that we know to date to the FDA. And at that point, the FDA starts their review and potentially approve the medication or reject. And then after a phase 3 trial and submission to the FDA, there is always more to learn. Some of these projects don't last very long. And as Sandhya mentioned, and all of you know, the rarity of bleeding disorders may not have many patients who participated at all. And so these phase 4 post-marketing projects are really important because we get long-term data. We get to, continue to see how things are working. We get to see long-term side effects. We get to see diverse populations. We get to see maybe different age groups that weren't approved under the application. We also can have a better understanding of how cost comparisons, if patients are infusing less or the medication's more expensive, we can start doing those comparisons to see how all of this kind of works out in the end. So those are the different phases of clinical trials. And so now we will go into the discussion of, how a clinical trial works, kind of behind the scenes, what all it takes and who all's involved. And so this is just a really elementary picture of who is involved. And, at the top, you've got your sponsor, your industry pharmaceutical company who makes the medication under study. And obviously, this box doesn't include everyone who's involved in these projects, but we've got medical monitors and we've got safety people. They hire external non-biased safety people to make sure everything is safe and the study should continue at different time points. And so there's a lot of people. I don't want to minimize just a sponsor. I mean, it's a huge team of people. The purple box, the CRO, that stands for Contract Research Organization. And those are also big companies most of the time who are hired by the sponsor to kind of manage the day-to-day. They are, I don't want to say middleman because it makes it seem like we can't get to the sponsor. That's not true at all. They are just a liaison that help facilitate communication. They are also experts in the trial. They know the protocol. They know what we need to do at the sites. And so they're a resource and help us execute the trials at the sites. And you can see at the bottom, the participating sites. And obviously this could be 100 sites. And so you'll see here that we all need each other for research to continue and for us to do great work and to be able to provide cutting edge therapies to our patients. We all need each other. And I enjoy the collaboration. And I think that we're better as teams and we are able to serve our patients well when we work together. And then just to go through the different roles. So the sponsor obviously is the drug manufacturer. They fund the clinical trial. They're in charge of designing the study. They write the protocol. They are in charge of the statistics and data analysis. They're in charge of quality control and making sure monitoring systems are in place. And by monitoring, I just mean making sure that the study sites are collecting data and cleaning data and making sure we're meeting all the regulations of conducting ethical clinical research. They are responsible for finding and selecting appropriate research staff and different vendors. Some of our projects, you probably know that a lot of our projects, we have to do logging. And so there might be an electronic diary that our patients log bleeds and infusions. We need to make sure that diary is going to work, because if patients can't use the device, then it's very difficult to get good data. So selecting qualified vendors is important. They need to make sure that we are following the protocol as it's written. Of course, for safety purposes, we could deviate from the protocol if needed, but we want to adhere to the protocol as it's written so that there are less variables when it comes to data analysis. They're also responsible for submitting regulatory documents to the FDA, whether it's the new drug application or the IND application that I was talking about earlier, or safety reports, the MedWatch reports that are required. They are responsible for providing the study drug to sites. They need to make sure that shipping and labeling and manufacturing and all of that is up to par. And then training. Throughout the duration of the study, they are responsible for making sure everyone assigned to work on the project is adequately trained. And then the role of the CRO, that liaison middleman, is it can be the sponsor could transfer all of those responsibilities that we talked about to the CRO. And so there are times when we work more closely with the CRO than the sponsor, but it's really up to the sponsor and CRO to determine that. And then us as site participants. So at every site, there is a lead physician who basically handles the clinical trial at that site. And we call that person, that physician, principal investigator, and for short, PI. We love acronyms. So the PI is responsible ultimately for everything that goes on at their center. So they need to make sure that all of the activities are in compliance with the protocol and the investigator agreement. They need to make sure that we are protecting the rights and safety and welfare of the participants. We need to make sure that we are submitting our study documents to what's called an institutional review board or an ethics board. And that is a group of individuals who review all of our study documents before they're given to subjects to make sure we are protecting the rights and safety of patients. They want to make sure as little risk as possible to the patient, and how we can minimize risk, and how they're responsible for reviewing the consent form. And we'll talk about the consent form a little bit later on. And so the ethics board and the IRB are a huge component of clinical research because we do want to protect our patients. The PI is responsible for training qualified site staff to conduct the protocols or the study. So if an infusion or an injection is needed, they want to have a nurse do that. If drug is involved, we want to make sure the pharmacy team is involved. If a joint exam or a musculoskeletal ultrasound is done, let's make sure PT is aware and can pitch in and help. And so the PI is really responsible for training and delegating different study tasks to the appropriate staff members. And then there could be, and oftentimes are, protocol amendments. So as you can imagine, as studies go on, we learn more and more and more. And that those findings may require a change to the protocol. So there might be, we might see that patients with HIV or hepatitis C react differently. And we didn't know this beforehand, but now we do. So let's change an inclusion or exclusion criteria to say, maybe we should reconsider the safety for patients with hepatitis C or HIV. And so things like that. When protocols change, we have to change too, and we have to be trained on those changes. So the PI is responsible for that. The study staff are responsible for recruitment. Obviously, we work with the patients, not the sponsor and the CRO. We are involved in recruitment, enrollment, and we complete all of the study visits. We are responsible for making sure the study drug is kept securely, separately from clinical medication. We want to make sure that it is stored appropriately based on the temperature requirements. We want to make sure that we are giving study drug to consented patients. And we want to make sure that we're receiving all drugs so that we can do drug accountability to make sure all of that has been done safely and according to the protocol. And then we are also required to keep study records. So all of our documents have to be retained for at least 2 years after a marketed drug. And the sponsor could require longer. Some of our protocols, we have to keep records for 15 years. So that kind of varies. But you'll see there's lots of work to be done by the different kind of team players in a clinical trial. And so now I just wanted to kind of talk about the flow of what it takes to get a clinical trial up and going, and the flow of how it goes through all of the different components of completion. So we've got study startup, then we move along to site activation. Then we're allowed to start recruiting and enrolling patients. And then after the study visits have all been completed, then we start moving into the data analysis, publication plans, study, making sure all the data is clean so that publications and submissions to the FDA can be made, and then study closure. And we'll go into detail on each of these. All right, so study startup. The first part is kind of what I like to think of as like the dating scene of clinical research. Like the site selection visit, the sponsor's like, hey, do I like Denver? Like, do they have great centrifuges? Do they have all the equipment that we need? What's, the physician's reputations there? Has the FDA been there? Did they have a good report after seeing them? And so that's the site selection visit, where the sponsor's kind of like seeing if they like us. The feasibility assessment is where the site is seeing if we like them. So they basically send us a protocol synopsis. We do a feasibility assessment with our feasibility committee. And the kinds of things we're looking for are, do we think this is scientifically sound? Do we think their protocol is pragmatic and reasonable for patients? Do we have patients that meet the inclusion exclusion criteria? Things like that. And so once they decide they like us and we decide that we have the resources to participate, we start to negotiate a budget and contract. And as that's going on, that's when we start working on the IRB documents, that regulatory submission that we have to do before we recruit or enroll any patients. And this study startup process can take months. It is a very laborious process, lots of back and forth, lots of communication, lots of questions between the sponsor, CRO, and site. And once we get all of these documents in place, we get a budget agreed upon, we get a fully executed contract, and our IRB is approved, we will be activated as a site. And at that point, that's when the training really starts. So pre-COVID, we used to go to principal investigator meetings, is what they called it. And they'd bring all of the participating sites and investigators to a big meeting, and they would train us on everything. It'd take days. Post-COVID, most of it has been virtual and like this. But training is super important. So we have our site initiation visit. After that, we start receiving study drug and all the materials that we need. So those e-diaries that I was telling you about, we'll get those. We will get our ISF, is the investigator site file. So all the binders that the regulatory documents are stored in, we start to really work on those. And as soon as that is all in a good place, we are activated and we can begin enrolling patients. So at that point, we try to already have a good idea. Back in feasibility, we looked at inclusion exclusion criteria, and we've been thinking about some patients that come to mind that we see who might be interested and eligible. And so at that point, we start to reach out to those patients and let them know about the study and gauge interest. Once we start enrolling patients and consenting and patients screen, and we basically follow the schedule of events. And so the protocols all vary. So some of our clinical trials can last 8 years, some last 5 years, some last 2 weeks. So it varies based on the study and what the intent is. And all during the study, where the patients are actually completing study visits, we are constantly reviewing safety. We are constantly having IRB changes. whether it's because of protocol amendments or new documents that subjects need to start using. Like maybe there's a new questionnaire that the sponsor wants us to ask. So there's constant regulatory work that's being done behind the scenes. We also need to submit UAPs, which stand for unanticipated problems. So anything that we didn't expect to happen, we have to report that and let people know. We need to, if there are new risks that we learn through the study, we need to change the consent form and submit that to IRB and reconsent patients so that they are aware of that change and can make a decision of whether they want to continue participation. And also throughout the duration of the trial, these monitors, we call them monitors, they're people from the CRO, they come to our site and they look at data. They look at the data that we collect from our patients. They look at the study drug and make sure that we are dispensing and receiving the drug, it's being used appropriately, all of that kind of stuff. And so after the study visits are done, we start the data analysis phase. We work really hard to clean up the data. Oftentimes we get queried like crazy towards right before database lock, which is when the sponsor CRO locks the database so no more changes could be made. And so after the data is clean and it's ready for analysis, the PI, the principal investigator at each site, has to go off and sign off on our case books of our patient data. And then once that's done, we complete a closeout visit. So most of the time the study sponsor will come to our site and tell us how long we need to keep our binders. If it's longer than the 2-year FDA requirement, they tell us that. They talk to us about if you hear from the FDA, please let us know because we want to come and help you prepare for any kind of inspection, stuff like that. We submit to IRB to close the study. And yeah, that is study closure. So that's kind of the flow of how a clinical trial starts up, how we move through the actual completion of the study, how we make sure the data is clean and ready for analysis and publication, and then how we close. And then the final point that I wanted to talk about today is you know, what are the good things and the bad things about participating in clinical trials? And I'm biased. I love research. I think that it is necessary for research to continue to progress the field. And so I just want to say up front that obviously I'm biased, but we will go through different pros and cons. And at the end, I asked some questions of past and current study patients. And so we'll get to hear a little bit of their perspective as well. So some of the pros or some of the good positives of joining a clinical trial. And I'm sorry, I'm just going to move. I'm having a hard time seeing. My face is everywhere. All right. So some of the good things about clinical trials, you could have access to a medication that's not available outside of a research setting. So novel therapies, new drugs that are only in an experimental trial is potentially a good thing. These novel therapies, they could be an improvement compared to the standard drugs that are on the market and available for commercial use. Patients could feel like contributing to science and advancing the field for future patients is a positive. And then, you know, some people, being in this investigational trial, using this investigational drug, they find comfort in knowing that the study visits that we conduct are done frequently, much more frequently than standard of care. At our center, most of our patients are seen annually, and that visit, we get a lot done, and it's a long visit. But in a clinical trial, having more frequent visits, some of our patients come weekly, and so, you know, having the frequent follow-up and the frequent blood tests, the frequent connection with the physicians and nurses and coordinators gives them comfort. And so those are just some of the positives. Some of the negatives or some of the drawbacks or challenges in participating in a clinical trial, we always hear, well, I feel like a guinea pig, or there's so many unknown side effects, and I don't even know if this, you know, medication is going to work. Oops. Yeah, I don't even know if this medication is going to work. So it's risky to take a medicine that we don't know much about. And we totally get that. We do try to minimize risk as much as possible. The study drug might not improve your outcomes. And, you know, we're trying to learn these things. The clinical trial requires a lot of time and a huge commitment. Like we said in the pros, the good things, there are more frequent visits. And so that means people are having to lose school time and work time. And that's difficult. So if your job is inflexible, that can be stressful and challenging. There's definitely more paperwork. We ask lots of questionnaires, and standard practice for non-research patients, we want people to log. That is difficult. I mean, I try and log my food intake on MyFitnessPal, and I don't even do good at that. So I get it. The logging is a pain. But for a research study where maybe annualized bleed rates is an outcome that we're trying to look at, it's an endpoint. If we don't have logs, we can't know that data. And so we really need comprehensive, really good logging to document, you know, bleed start times, how many infusions did it take for your bleed to resolve, stuff like that. Sometimes those bleeds are through a device like a phone, sometimes they're on paper. And so there is a lot more involved than your annual comp visit through a research study. When you come to those study visits, you may do a lot of research activities. So you might just be used to having a PT exam at your comp. We might need to do it for the study every 6 months. We might need to do MRIs of your joints. We might need to do musculoskeletal ultrasounds. We definitely do more lab collection because that's where we really see safety. We're able to look at inhibitor status. We're able to look at factor levels. We're able to look at liver enzymes, the typical CBC, CMP, things like that. For PK studies, so pharmacokinetic studies, those require frequent lab draws because we're trying to determine your peak and your trough and how long that takes for you to be completely washed out of a medication. So lots of activities involved in a research study that aren't typically required standard of care. And then maybe a con of participating is the close monitoring by the study team, the frequent sample collection. You know, sometimes patients might show up for their comp and the physician has no reason to believe they have an inhibitor, so they don't even collect any labs. And, you know, it's difficult in a clinical trial because we do need frequent sampling. The frequent follow-up from the study team, I can't imagine anyone would be disappointed hearing from me often, but we do call our patients, we email them a lot, we text a lot. The study visits in person, During COVID, we've learned that we can do a lot remotely. We can still assess safety. We can still ask questions. We can still see each other and feel connected through Zoom. And so if you decide to participate, just be aware that you will be plugged in and talk to your study team a lot. And then we talked a little bit earlier about the most important component of a clinical trial is informed consent. And this is the main thing that matters in human subjects research. We have to get this right. The informed consent is a document, but it is a process that really needs to be ongoing throughout the duration of a whole clinical trial. Yes, we need it at the beginning before we do any research activities. Yes, we need that first, but we need to keep patients informed as things change. And it really just needs to be a discussion that's ongoing throughout a subject's participation. Ultimately, uninformed research participants, patients who don't know, equals missing data. And missing data in clinical trials can really sink the progress made. And so it's our job as the study team at the site to do a really good job at communicating the expectations, all of the risks. Let's see. So yeah, like I said, the PI and the delegated study team members, we are the ones who present the consent form and present the study and the expectations. We tell them the purpose of the study, why are we doing it, who's eligible, what's required, what do we need you to do if you decide to participate, what are the risks, and how are we going to minimize those? Are there any benefits directly to the patient? Is there an alternative treatment if you don't want to participate? Making sure they know that the participation is voluntary. We need to inform them if they're going to get paid or what they have to pay for. Oftentimes, the research procedures are always covered by the sponsor, but everything that's standard of care that would happen regardless of study participation is something that the patient or their insurance company might be responsible for. So we need to disclose that. Obviously, who to call for questions. And then we go over HIPAA and how we protect your private health information, who has access to see your personal information, stuff like that. The consent process is required to be done in a private, quiet exam room. We want our patients and their family members to ask questions. We want patients to start a study with a good understanding of why we're doing it and what their involvement requires. To ensure comprehension, we like to ask questions, just, hey, why, can you tell me why we're doing this study? Can you tell me how long you're going to be in the study? Can you tell us, just try to get an understanding of whether they comprehended what they're actually signing up to do. And then we also give them a copy of the consent form. And my patients and my studies, we go over the schedule of events at every visit with the consent form. And so we basically have the consent document at every study visit, and we go through and say, okay, next time I see you, we're going to do this, this, and this, and this. We've talked about this. Anytime there's a change to the consent form, we're going to reconsent patients because they need to know new information, the different information that wasn't previously presented, so that they can make an informed decision whether that changes their willingness to continue participation. Need to be included in the informed consent document. Again, the statement that this is a research project and it is voluntary. Why are we doing the study and how long? What are the procedures that you're going to have to go through? What are the foreseeable risks and discomforts? Are there any foreseeable expected benefits? Are there alternative treatments? Are we going to pay you? Are there things you have to pay for? And then HIPAA. And in case people aren't aware, most of the ICFs, they start, the first iteration is written by the sponsor, and it comes through the CRO to the sites. And the sites then have to take the template that the sponsor has provided and work it into our own IRB templates. And so your study team is basically taking the template information into what our regulatory board needs in order to approve the document. And so there are lots of people involved in making sure this document is clear and concise and written in language that can be easily understood. We do have minors that participate, and for young children, there's an assent, and subjects 7 to 12 sign that, and then anyone older than 12 can sign the consent with their parents or legally authorized representatives. And so, long story short, the informed consent form is the most important document in clinical research. We want our patients to be informed. We don't want there to be any secrets. It's kind of like you're laying on the operating table and the surgeon says, "Oh gosh, I've never seen that before." As a clinical research coordinator, you'd never want to hear your study subject say, "Oh, I didn't know I needed to do that," or "Oh, I had no idea that was a risk," or "Oh, I wish I'd known that before I did this." That's the worst case that could happen. We want to inform our patients. All right. And then, so questions that you should be asking your study team before you sign the consent. Make sure you know the purpose. What do you have to do if you participate? How long are you going to ask me to participate? What if I decide not to participate today? Or what if I say yes now and say no in a year? What happens then? And to answer that, that's fine. It's always fine. There may be some safety procedures that have to be done, like maybe we need to keep checking a few more labs, but you're always able to withdraw from a study. What are risks and discomforts? How we plan to minimize those? Are there any direct benefits? The payment thing. How will my data be shared? What data will be shared? Is there randomization? Might I get a placebo? Who can I call for questions, alternative treatments outside of a study? What happens if I'm injured while in the study? And who is going to pay for that injury for me to receive care? Will I be told new information that is learned through my participation? Am I going to be given my research results? And there are tons of other questions, but we basically want to ensure that patients are informed and they know all that's expected and continue throughout the duration of the study to learn. As we learn, we want to disclose new findings to patients. The difficulty with clinical research is that it is research. There's always going to be an experimental piece of investigational drug studies. We don't know everything, but the data that we do learn, we do tell our subjects. The clinical trials are highly regulated. There are lots of different layers of oversight ensuring the protection of patients is priority. And I can't stress enough just the need to have constant dialogue and always asking questions with your study team. The principal investigators that we work for, they love questions. We want the clinical research experience to be positive. We are collaborating with the sponsors and CROs, and we want to provide feedback for improvements in the patient experience for clinical trials, because we all need each other. And so we want patients to enjoy their time on studies so that we can continue to progress science and provide cutting edge opportunities to our patients. And unfortunately, I was hoping that one of my patients could join and we could do like a live Q&A, but it's summer and COVID is better. Thank you for that. And so they are traveling, the ones that I thought might be willing to do it. The others are too shy. And I guess next time I'll put it in the informed consent form that says, you know, you might have to do a talk with Julie. But I sent some questions to a few patients and they responded. And so I just wanted to share a couple of questions and answers from some of our patients that we have worked with on trials. So a 51-year-old male, severe hemophilia patient, he's actually been on several of our studies through the years. And my question, how did you first get involved in clinical research? His answer, many years ago, I was having some trouble with insurance and an opportunity came up for me to try a new factor product through a research study. Same patient, did you actually end up enrolling in that trial? His answer, yes, and I've been in several other studies since that first one. Can you tell us what it's like to be in a research study? He answered, well, I had to come to the Hemophilia Center much more often than I normally would, which actually I don't mind. It allowed me to have a closer relationship with the coordinators, the nurses, and the doctors at the center. I also got reimbursed for mileage, so that helped. At the visits, I usually had some blood drawn, had to have other things done like blood pressure and weight. I had to keep all of my study medicine vials, even used vials, and return them to the Hemophilia Center. I wish I had changed my voice to try and sound more like him in his answers, but I didn't. I won't do that. And then I asked, what was your favorite part of being in the study? His answer, trying something new that might help younger people have a better future than I had. What was your least favorite part of being in the study? He answered, having to shave my chest for the study visit so we can do an EKG, itchy. He complained about that for a very long time. And then I just asked, is there anything else you would like to add about being in a study? And he answered, being in research studies has given me a chance to help future kids with hemophilia, also build a great cooperative relationship with the Hemophilia Center. Deciding to be in a study can be a hard decision, especially if you're deciding for your child instead of yourself. However, I think that my experiences have been very positive, and I really enjoyed coming to the Hemophilia Center for my study visits and trying new meds. Second patient, different patient here. A 35-year-old adult male. How did you first get involved in clinical research? Same questions. And he answered, I was interested in gene therapy that isn't available outside of a research study. I imagined if the new medicine made it to market, it would be really expensive. So I wanted to have access to the medication while it was free in the study. Did you end up enrolling? He answered yes. There was the lead-in study before the drug study, and I've been in both. Can you tell us what it's like to be in a research study? He said, well, it wasn't a rash decision. I thought about it a lot. I talked to my wife and parents about the study and my interest. I talked a lot to the study team and asked a lot of questions. I considered time off work, but luckily my job is flexible. I'm able to easily do study visits when they're needed. It's been a big commitment, but it's been worth it to me. I've enjoyed working with everyone involved in my care at the HTC. What's your favorite part? The study medicine has worked well for me so far. My bleeds have been reduced and I don't have to infuse as often. What was your least favorite part? Having to give so many specimens. I understand the importance and the need for testing them, but I've been giving them for a long time and I'll be glad when that part is over. And I will too. Is there anything else you would like to add about being in the study? And he answers, I hope that my participation will help others. I hope that the study continues to have positive results and will be available to others with hemophilia. So those are just two perspectives of a couple of patients. And I leave you with this final slide here. The common goal for everyone in clinical research is the same. The patient, us at the site, the sponsor and CRO, we all want our patients to have happy, healthy lives. We want to just continue to improve outcomes and quality of life. For the patients out there, I encourage you to reach out to your team at your HTC or where you receive your hemophilia care or von Willebrand's disease or any of your bleeding disorders. Reach out to whoever you work with and see what kind of research opportunities there are for you. I also listed here the clinicaltrials.gov website. That is a requirement for drug studies to be posted. And so I encourage you to go on that website and look and see what might interest you. And I just want to thank all of you for spending a little bit of your afternoon and evening with me. I am passionate about the job that we do. I'm passionate about the progress that we've made, and a special thank you to our patients, because you inspire us to do better and to be better, and you give us hope that tomorrow can be better. And it wouldn't be possible for us to do any of this without your trust, without your bravery, and without your altruism and just helping others. So thank you very much. And Sandra, I think it's back to you, my friend.
Yeah, thank you so much, Julie. I think that was a really great look into the world of clinical research. So often I think us as patients maybe think it's just signing away and showing up for those visits. So to get a glimpse behind the curtain was really valuable today. So thank you so much. Really appreciate it.
Thank you. You guys have a good night.
Thanks. Just a few housekeeping things as I send you off to your wrap sessions. That's the word I'm looking for. Just want to thank our sponsors again: CSL Behring, Hemobiologics, Genentech, Sanofi Genzyme, and Spark Therapeutics. We again just really appreciate the support. Glad everyone is here today and able to join us. As you are leaving, a brief 5-question survey will pop up on your browser screen. We ask that you take just a minute to fill that out. We really value your feedback and want to hear your thoughts on this session today and tomorrow too. We hope to see you again. As I mentioned earlier, the wrap session links are in the email that you received this morning. If you don't have the correct link, or you just was missing it altogether, send me a chat here in the box. I will get that to you. I'll leave this meeting open for a few minutes to make sure I catch anyone that might not have that link. And then finally, we will see you tomorrow. Tomorrow is our final day. It's a bit shorter day. We only have a couple of hours of programming tomorrow, but we'll hear from some experts in research again, but more, or let's say less medical research and more patient-centered research that is really looking at patient perspectives on how and experience. So stay tuned for that. And then tomorrow afternoon, we have a great speaker to talk about new and emerging therapies for bleeding disorders. So we'll hear more about those new products in development and that are currently in clinical trial. Again, thank you so much. Thank you to our speakers. Thank you to all of the HFA staff that's been supporting all week. Really appreciate seeing everyone, and we'll see you tomorrow. Have a good evening.